I think a lot of the hesitancy actually comes from not just sickle cell being a rare disease and providers not being comfortable with sickle cell disease, but also because menopause itself is not on our radar. Nationally, we're making more of headlines on menopause as well as women's health. I think that's actually going to help us overcome some of these barriers. So, both looking at sickle cell as a lifespan disease, which has been the rhetoric in the past decade, and then also starting to shift our focus to women's health issues as they age.
Welcome to Collaborative Endeavors, a podcast about how scientists from different areas of research come together to tackle big health challenges, leading to better therapies and healthier communities. Today we are highlighting one of the Center for Clinical and Translational Sciences' recent Implementation Research Pilot Awards. Led by Dr. Marwa Faruqi, an adult hematologist and assistant professor in the Division of Hematology and Oncology, this project seeks to implement a menopause screening tool for women with sickle cell disease. Also supporting this effort are Dr. Galila Goba, a gynecologist with a research focus in improving health outcomes related to women disproportionately affected by disparities, and Dr. Louis Su, professor of pediatric hematology and oncology and director of UI Health's Pediatric Sickle Cell Center. Together, the team is trying to revolutionize the future of sickle cell care to meet the evolving needs of their aging patient population. Dr. Faruqi explains how this project was conceived.
This project idea came from my patients themselves. As I started building my practice with women who are aging and potentially going into menopause, they were asking me, hey, what happens as I go through menopause? Are some of my symptoms related to menopause? And I was at a loss of words. I did a literature review, and at that time, I noticed that there was only one study done out of Brazil at that time in a very small subset of patient population. And I quickly realized that we don't know much about menopause in this unique patient population. So that's kind of how it started. When we're talking about sickle cell disease, there's multiple symptoms that these patients can present with, and they may have significant comorbidities as well as end organ damage that really confound the diagnosis when you're trying to figure out, hey, is this sickle cell itself that's causing this, or is it some other issue? Perimenopausal women often deal with hot flashes as well as mood swings, insomnia. They may have joint pain, arthritis type of pain as well. And then they may have genital urinary symptoms such as vaginal dryness, recurrent UTIs. Some of these symptoms are also common in patients with sickle cell disease. We often see insomnia. We often do see urinary tract infections in women with sickle cell disease, as well as vaginal dryness. Pain is notorious in sickle cell disease. It's more of a vaso-occlusive pain episode, but have all these years have we been labeling it as a vaso-occlusive episode and ignoring, hey, this could be potentially related to the pain of aging and going through different menstrual cycles in life. So, anytime there's two diagnoses going on, we as physicians always have to take a step back. With sickle cell disease, it's even more of a convoluted picture. So, the first goal was to try and distinguish the symptoms of menopause from sickle cell disease. And really, there are no biomarkers for sickle cell disease for menopause itself in the sickle cell world. When we first started collecting our preliminary data, we noticed that we don't even have the last menstrual period being collected for women, let alone, a conversation around menopause or their menstrual cycle. So the goal was to try and change that clinical practice and raise more awareness amongst healthcare staff as well as providers. So, really, this implementation science project is centered around trying to establish a way of menopause screening in the sickle cell clinic by sickle cell healthcare staff and providers. Dr. Su's expertise in implementation science comes in because of his track record. And that's why he's one of my co-Is. And Dr. Goba helps me with the menopause and the gynecology aspects of it that I don't understand yet.
If it seems counterintuitive for a hematologist to screen their patients for menopause, the team agrees. They explain how the unique relationship between sickle cell providers and their patients creates a situation where they become the de facto healthcare provider, regardless of their expertise or lack thereof. While this creates obvious challenges, in this case, there was an opportunity as well. Here is Dr. Gova.
When Dr. Faruqi came to me with the idea, I was very much excited and happy because menopause is part of a woman's chapter of life that we don't necessarily screen routinely, as well as um, provide option for the management of very much significant debilitating symptoms that affect their quality of life. For example, they come with like not able to sleep, and particularly if these are women who have a full-time job, or for example, if you have to wake up in the morning and go to your work but you haven't slept, this significantly affect their normal day-to-day life. They're not able to focus on advancing their careers because this is also the time that women are actually very much productive and at the higher level of their profession. There are issues related to urinary incontinence, vaginal dryness that Dr. Paripi just explained. So the fact that we don't really address it really well in general in the general population as one major problem, the sickle cell population is a very special population. I do completely agree with Dr. Faruqi that when they come to us, particularly it is for bleeding, but when it comes to routine care, they trust their sickle cell doctors. And they probably give a lot of weight as well for what to do and not to do. So filling this knowledge gap and addressing it as a problem was something that I quickly jumped on. In general, women with chronic illnesses have usually go through life transition sooner than normally expected. That will be the age of 51 for normal general population. But whenever a person goes through menopause before the age of 40 or around that time, we call it premature ovarian failure, and that's essentially its own health risk. And what we anecdotally discussed was that most of our sickle cell patients actually now they survived treatment and quality life has improved. They are now living past the age of 35. And that is how they are voicing their concern to the patients are coming up with a problem. How can we, from the provider side, would be able to help?
Dr. Su added his perspective.
On the one hand, I was sitting here going, what on earth am I doing here as a pediatrician and a hematologist having anything to do with menopause? Completely foreign to me. But I realized also that this is probably, part of the problem that previously the care of sickle cell has been mostly in the hands of pediatricians, for whom menopause is about the farthest thing from our minds. And so many of the quality measures and structures were not set up with anything like this in mind. It was just about surviving into adulthood and about things that are immediately life-threatening or potentially life-threatening. And so I think that much of what I'm trying to contribute is the idea that the goals and the comprehensiveness of care for sickle cell needs to change. Not quite a revolution, maybe, but at least having quite a bit of change. And what we've come to find is that medical systems don't like to change. People just don't like to change. And implementation science has now given us new tools to help manage that better and smarter. And so having implementation science frameworks and tools and tricks maybe can make stuff happen smoother, more efficiently, not waste so much time relearning things. So what I'd like to bring to this is the small experiences that I've had that could translate into faster implementation of what's a very, very reasonable thing to do, but got to get people to change.
For those who are new to the field of implementation science, the NIH defines it as, quote, the study of methods to promote integration of research findings and evidence into healthcare policy and practice. Researchers commonly use an established model or framework to determine how to best move an intervention into a real-world setting. In a nutshell, these models help guide conversations with key stakeholders, identify factors that can help or hinder progress, and solidify processes to integrate this new thing as seamlessly as possible for those doing the work without jeopardizing the outcomes. If you're interested in learning more about these models, we've included some links in the show notes. Dr. Faruqi landed on the EPIS framework for this project. And during the exploration phase, the team identified a menopause screening tool already in use in Canada, South America, and Asia. Developed by Dr. Susan Goldstein, Menopause Quick 6, or MQ6, is used to screen, diagnose, and manage menopause in busy primary care settings. The team then worked with a panel of sickle cell and menopause experts, as well as sickle cell patients themselves, to design an adapted version of the menopause questionnaire. The idea is that anyone who screens positive for menopause would automatically be referred to gynecology or a menopause expert for a definitive diagnosis and treatment plan. The team was off to a strong start, but as they moved into the preparation phase of the EPIS framework, they began to encounter those barriers to implementation. Here's Dr. Faruqi.
We did like a preliminary needs assessment, both with the patients as well as the sickle cell healthcare team to determine, if is this even feasible in our center? Do people care about this? And we did find out, patients were loud and clear. Women wanted us to address their menstrual health. And providers, did note that it was an important topic that needs to be looked at more closely in terms of aging and sickle cell disease. I was thinking, hey, it's not going to be a big deal. We can do it. All the providers were excited. And I was like, let's go, let's do it. And then I actually talked to the providers one on one because as a team, everyone says yes. But when you talk to them one on one, even nursing staff, they show hesitancy because we're all limited for time. And reasonably so. Time and space are always a limitation, no matter what. So at this time, we have a really robust clinical research center at UI Health for sickle cell disease. And I did brainstorm with some of our research coordinators who have done other survey type of projects before to see what their thought process was. And they also said, hey, this is not going to be feasible for you to expect the providers to do this or for you to expect the nursing staff to do this on every single patient. Is there a different tool we can utilize? So what we ended up doing is we are trying to embed the screening tool that we have come up with, the adapted sickle cell screening tool, in the EMR itself, where it's given to the patient's BMI chart. And even prior to coming into their appointment, they are able to answer these 8 questions. Even with trying to embed it into the EMR, it will be difficult because providers don't like best practice alerts. I don't either. And then I'm working closely with the clinical informatics to see how we can roll this out. It's sort of supposed to be similar to how in the COVID pandemic, we would ask the COVID questionnaire before the patients even came in. So we're trying to model off of that.
What's underpinning some of this too is that this is not a high-resourced clinic other than that we have research assistants around. And this is part of a population that has been hit with all kinds of health disparities. Sickle cell disease is practically a poster child for underserved populations' health disparities. And to be able to bring advanced services and new things is remarkable, and be able to navigate the system using some of the tools of implementation science is what this project is about.
As our conversation neared its conclusion, the team talked about some of the greater contextual challenges around this project. Dr. Gober, for one, addressed the fact that, particularly in the United States, women are often forgotten about after their childbearing years. Dr. Faruqi elaborated on some of these challenges as they pertain to aging sickle cell patients specifically.
I think a lot of the hesitancy actually comes from not just sickle cell being a rare disease and providers not being comfortable with sickle cell disease, but also because menopause itself is not on our radar. I don't remember learning about menopause in detail in medical school, and as we go through internal medicine residency, it's almost never talked about. very few primary care doctors address it. So really, at least in the United States, it's been very focused on either if a family practitioner tends to specialize in women's health or it's focused in the gynecology setting. So I think the biggest barrier is going to be education. As nationally, we're making more of headlines on menopause as well as women's health. I think that's actually going to help us overcome some of these barriers. So, both looking at sickle cell as a lifespan disease, which has been the rhetoric in the past decade, and then also starting to shift our focus to women's health issues as they age.
Dr. Sue also commented on the potential for aspects of this project to be translated to other chronic diseases.
To be able to try to do this in a setting that is complex medical care already and in a urban underserved population will be remarkable. And so this could be a demonstration project for other disease conditions too, where there's lots of stuff going on, but menopause potentially could be impairing or impacting what else is happening for other multi-system complex disorders.
The mortality and the life expectancy of individuals with sickle cell disease is almost 2 decades, if not more, lower than the average life expectancy. Now it's reported that the average life expectancy of a patient with sickle cell disease is 54. As we continue to make headway on that number, I want my patients to be able to age gracefully and not be down because of their disease. So, Dr. Goba had mentioned, when you undergo menopause at an earlier age, when you have premature menopause or early menopause, it does have significant outcomes, not in terms of just the menopausal symptoms that I'd mentioned earlier, but also cardiovascular health. And in a disease such as sickle cell disease, which already has some predisposing cardiac and neurological comorbidities, this could mean a lot. If we're catching these patients early on, diagnosing them, and treating them appropriately early on, we may be able to make more headway into improving their quality of life as well as the quantity of life as they age.
Collaborative Endeavors is produced by me, Lauren Rieger, on behalf of the Center for Clinical and Translational Science, aka the CCTS, at the University of Illinois, Chicago. To learn more about this team and the field of implementation science, visit the links in our show notes. The CCTS is supported by the National Institutes of Health's National Center for Advancing Translational Science through their Clinical and Translational Science Award. Opinions expressed by guests of the show are their own and do not necessarily represent the views of myself, the CCTS, or our funding agencies. You can find more episodes of Collaborative Endeavors on Apple Podcasts, Spotify, Amazon Music, and Google Podcasts. While we do not monetize this podcast, we do love positive feedback. If you like what you hear, go ahead and give us a 5-star rating to help spread the word. To learn more about how you can work with the CCTS to make a positive impact on the health and well-being of our community, visit ccts.uic.edu or follow us on X at UIC CCTS.